Good evening, everyone. It is our honor to introduce Professor Salman Sharif, a globally respected neurosurgeon whose contributions have shaped the field internationally. Professor Sharif earned his FRCS in general surgery in 1993 and completed his FRCS in surgical neurology in 1999. Since then, he has served as chief of neurosurgery at Liaquat National Hospital and Medical College in Karachi, Pakistan. He is the current coordinator for the WFNS committee activities and the dean of the Faculty of Neurosurgery at the College of Physicians and Surgeons, Pakistan. His leadership roles include past chair of the WFNS Spine Committee and past president of several major societies, including the World Spinal Column Society, Pakistan Society of Neurosurgeons, and Middle East Spine Society.
Professor Sharif is a leader in the international neurosurgical community, serving on executive committees of organizations such as the International Federation of Neuroendoscopy, Asian Congress of Neurosurgical Surgeons, and the Asia Pacific Cervical Spine Society. Academically, he has authored over 127 publications, 12 book chapters, and 3 books, and serves on the editorial boards of leading journals such as World Neurosurgery, Asian Journal of Neurosurgery, and several more. He is a leader in education, having organized more than 250 webinars, garnering over 190,000 views, and led more than 40 national and international conferences, including the first ever virtual neurosurgery congress. Thank you so much for joining us, Professor Sharif.
Thank you very much.
And just to give Dr. Sharif a sense of, we have two audiences here, the Mayo audience and the outside audience, which tends to be very global. But is if we could just go around the Zoom here and just have the Mayo audience introduce themselves. I'll introduce Dr. Denomi. She's a chief of neuro-ophthalmology. If you ever need a global neuro-ophthalmology for the neurosurgeons course, virtual, Dr. Denomi is your right person. But why don't we start at the upper left with Dr. Todeschini? Why don't you introduce yourself, your role in the department, and then we'll go around the Zoom. Go ahead, Alex.
Sure. Nice to meet you, Dr. Sharif. My name is Alex Todeschini. I am a Brazilian neurosurgeon. At the moment, I am a research fellow at the skull-based lab here under Dr. Bandak, and soon I'm going to start my clinical fellowship with him.
Amir.
Superb.
Hi, Dr. Sharif. Nice to meet you. I'm Amir Sigari. I'm a research fellow here with Dr. Bandak, originally from Iran. I finished my med school in Iran.
Perfect. Mr. Carlson.
I'm Brian. I'm a first-year medical student at Mayo, interested in neurosurgery.
Brandon.
Hi, Dr. Sharif. My name is Brandon. I'm a recent graduate of Mayo, Arizona, and incoming intern to the Mayo, Arizona Neurosurgery Department.
Ms. Olson.
Hi, Dr. Sharif. Welcome. It's very nice to meet you. I'm Vita. I'm a research assistant here in Dr. Bendak's lab.
Ms. Garcia.
Hi, Dr. Sharif. I'm Serena Garcia. I'm a neurosurgery PA fellow here at Mayo Clinic.
Dr. H. Dr. Hudson.
Hi, yes, thank you so much for joining us today, sir. My name is Dr. Hudson, or Miles. I'm one of the PGY5 neurosurgery residents here at Mayo Clinic, Arizona.
Dr. Singh.
Hello, Professor Sharif. I am Dr. Gaurav Singh. I am currently adult and pediatric comprehensive spine deformity fellow at Mayo Clinic, Phoenix. I have done my residency from All India Institute of Medical Science, New Delhi. Nice to meet you.
Dr. Denomi, you met. And Mr. Default.
Hi, Dr. Sharif. My name is Matt Default. I just finished my third year of medical school at Midwestern University here in Arizona, and I'm soon to be starting a research year here with Dr. Bendak's lab.
Samantha.
Hi, my name is Samantha. I am a volunteer in Dr. Bendak's lab. I'm a pre-med hoping to apply to med school soon.
And Angad.
Hi, Dr. Sharif. My name's Angad. I'm a fourth-year medical student here.
Avi.
Hi, Dr. Sharif. My name's Avi. I'm a PGY3 here at Mayo, Arizona.
Juan.
Hello, Dr. Sharif. This is JP. I work with Dr. Q in Mayo Clinic, Florida.
And then our youngest attendee, Alex, who's almost done with college. I think he's 11. Alex, go ahead. Do you have audio? If not, we'll go on to Charbel.
Hello, sir. I'm the neurointerventional fellow with Dr. Bandak.
We should say malnourished because he's been working around the clock. Malnourished fellow. And then Dr. Krishna. He may not have audio. Dr. Krishna is one of my colleagues in the department, a fantastic cranial and spinal surgeon. So, and then of course, we have our international audience. What I'll do is, for our national attendees, just send us the city and country you're logged in from, so we can share that with Dr. Sharif, and he can see the list of your names on the list. So please, Dr. Sharif, go ahead.
Thank you. I think it's amazing. I don't know, Bernard. I thought I was busy. It seems like you're going nonstop. And the collection that you have, amazing group of people, and I'm sure you're doing great work. It's really my pleasure to be here. I apologize. I think I clicked the link for tomorrow, and I was going there, and there was nobody there, and I said, maybe the time has changed or something.
That's the beauty of WhatsApp. I was able to get you in a second. So
yeah. So that's cool. When I was asked to do this, I thought, I do lots of spine. I've been spine committee chair for a while, so I thought it would be a good idea to talk about spine. So that's what we'll do tomorrow. Today, we're going to start with some cases. And then once we have done that, then we can move on to talk about some basics, how I started, where I went, etc., etc. Let me just share this. And 1 second. Let me just move it up. I'm sharing, but I don't see where I can make it. There we go.
in results, do we have chat turned on?
Let me see.
Yes, we do.
Okay,
Everyone should be able to use the chat.
Thank you.
What happened there? Let me stop share and then go back in. Let me see.
It looks great on
Can
our
you
end,
see?
Dr. Sharif. We can see well.
All right, brilliant. So I think we'll start with some cases and see where we go. Let me just minimize this. So I thought it would be a good idea to go through with some spine trauma and maybe something that we see routinely in this part of the world as well. So this is what we see all over the world. So let's present a simple case. Sorry, I couldn't resist. This is K2, which is the second tallest peak in the world up in the north of Pakistan. And one day I'm hoping to go there, but I've been to the base camp, not beyond that yet.
Wow.
So amazing. It is amazing. So Bernard, you may not know, but out of the top 10 peaks in the world, 6 are in Pakistan, in the north of Pakistan. Yeah. So 54-year-old presented through emergency with history of trauma, car rollover. His GCS was 15. He had quadriparesis. He was ASIA-A, intact sacral sensation, pain and tenderness of cervical spine. And this was his CT on arrival. Anybody wants to take that? Is there anybody who would like to comment on this? There's no trick question here, simple.
Brendan, since you're going to have to deal with this soon on call, what do you think?
Yes, sir. So we're looking at a sagittal CT of the cervical spine. I believe we're seeing some subluxation at 6 anterior to C7, with perhaps some disruption of the anterior longitudinal ligament. I would also be on the lookout for fractures, and I'm trying to see if I'm not sure if I can appreciate any distinct fractures, but I'm not sure if that's just my computer being kind of low resolution.
So you can see this is broken here at the back. And you can see both these joints have gone on top of each other. So there is fracture dislocation, yeah? Okay. So this is what we see, and we see all these fractures and overlapping. And you can see a double facet joint. So that is overlapping because of fracture dislocation. So, how do we go about sorting these patients out? Obviously, then we look at various classifications. So there are subaxial spinal injury classification. And in that, if you see that this is rotation, translation, facet dislocation, so we give 4 for this. As we saw previously that the posterior ligamentous complex was also taken and the disc is taken as well. So we know that the score is going to be 2 here. This patient has incomplete cord injury, so gets 3. And that's because of continuous cord compression, the neuro deficit, obviously with score of 10, we think about doing something for this patient. So what would you do for this patient?
Well, I believe for this patient, you want to tackle that?
Yes. So for this case, with a 3-column injury, I think, the key step here would be stabilization. And for that, for this patient, in the location of the cervical spine, probably some kind of anterior posterior approach, including anterior discectomy and fusion, followed by a posterior decompression and instrumented fusion.
So if this patient came to ER, what is the first thing you do? This patient is stable, but what's the first thing you will do?
The first thing I would do is get a neurologic exam.
Yeah. Okay. So neurological exam, then we go through exactly what kind of ASIA, etc. it is, and we just said it's ASIA B. And then we look at AO as well as SLIX. We use both these classification systems for our prognosis. And you see here clearly it's bilateral facets are gone and it's C. So here we go. And on top of it, obviously, we have this subluxation and bilateral facets are gone. So then according to the algorithm, we follow depending on neurology, modifiers, and depending on that, we decide what this patients need. So can we do a close reduction here?
You could do a closed reduction in the OR. I would consider it, possibly Gardner-Wells tongs under neural monitoring though, and under anesthesia, possibly.
Okay. Would you do an MRI first?
Yes. I sorry, this was assuming we've had all the proper imaging and workup to make sure there's not a large disc herniation or hematoma or anything like that.
Yeah, so here what I'm showing is that maybe if the disc is out, then ideally you should do an MRI. Having said that, let me just go through this. Obviously, with close reduction, you need awake patients. Reduction can be performed with monitoring. It's not recommended to obtain pre-reduction MRI if you don't have MRI straight away. We have 2 MRIs available, so we do in all our cases. But whenever there is a delay, we do not stop, we just move on. And the reason for that is the incidence of extruded disc is 0.7 to 42%, but the neurological injury is less than 1%. So, it's not a problem. And the guidelines say that if you don't have an MRI, because these guidelines are meant for all over the world and not just for the West. So we say you can reduce anterior or posteriorly. Obviously, both have their pros and cons. So disadvantage of MRI obviously is the delay, patient is shifted elsewhere and waiting, etc. So that could be an issue. So while you're waiting, would you do anything for this patient besides if you're waiting for an MRI and you have maybe looked at his vitals? What would you like the vitals to be?
For a patient like this, after acute spinal cord injury, I'd like to keep the maps up greater than 85 in this case for 48 to 72 hours. In the post-operative setting, we can use neuromodulatory medication, but I'd also want to make sure this patient was stable, so I'd keep them in a collar. I wouldn't do steroids or anything like that.
Okay. So patient like this would probably benefit from tongs and a little bit of traction. That would stabilize. We know once you put in tongs, you open up the canal by 30%. So that's generally recommended. What about open reduction? Can we do that? Yes, we can. So would you do anterior or posterior, Miles?
In this case, I would probably do a combined approach. Depending on where the pathology, it looks like it was compressed. Like if it was very large disc from the front, I might come anterior first, but I'd have to see the scans and the MRIs and look at them. But I'd probably do a combined approach.
Yeah, I think you're very right. In majority of the time, that is the case. So there are both advantages and disadvantages. So anterior approach, you can do a single segment arthrodesis, low infection rate, 1 in 600 kind of thing, high union rates, better lordotic alignment. And, the only problem is you can have voice changes and dysphagia. So reduction techniques, Miles, what are the reduction techniques that we use? Sorry, I got stuck. Is there anybody else who wants to take this?
I can answer this one real quick. Just while I guess I'm here, there's a lot of different reduction techniques depending on your approach. You can come from the front and anterior, and then you can do something like you see in the pictures, like a cantilever technique using spreaders. You can also do it with the Caspar pins, TP them, lift up and over. If you're coming posterior, you can do an open reduction from the back as well, using a cantilever technique with the facet joints or just drilling out the facet joint directly to get reduction.
Yeah, you're very right. The only problem with this is if you don't put your distractors in the right place, spreaders in the right place, you can break this part of the vertebra and cause fractures. So you need to be careful. So for whichever side, if it's a single side subluxation, obviously you put your spreader there, and then you can use your hand from the back and push that bit of spinous process so you can move the whole thing. And it's quite simple. And then, as you just said, vertebral body pulse technique, and it is simple that you bring in, coming in, on these screws, and then you straighten them out, and automatically the facets will open up, and then you can easily reduce. Depending on which side it is, you can rotate and fix, and you can push with your finger from the top as well. So these are simple ways of sorting this out. Okay, so we have this MRI. Can we predict in this patient what kind of outcome this patient is going to have? Anyone? Okay, so what we are seeing is this contusion, which is
T2
going
signal
from here.
changes are there, sir,
Yeah,
in the cord.
yeah.
So there is a cord injury.
Okay, good. So the prognosis, there is a score that we use. Do you know what score do we use? So this is the score we use. This is a basic score. And depending on this basic score, we can predict the outcome. So for example, if it's 0, there is nothing damaging any part of the cord. You have 92% of the people who are discharged with HCIE. If it goes up to slight bit of involvement of gray matter, then it goes up to D. If there's moderate bit of involvement, then this can be anywhere from A to D, but at the time of discharge, 88% will go to C to D. Whereas basic score 3, obviously, there is a whole of the spinal cord is involved, just like our patient, so they may not have that kind of outcome. If somebody who's got these hemorrhages and snake eye signs, these patients unfortunately do not walk and do not have got very bad prognosis. Having said that, we try in all our patients. So will you give steroid to this patient?
I would not.
Okay, good. So there's not recommended. There is no evidence that it works. In fact, there is evidence that it has harmful side effects, including death. Okay, let me see. And then immobilize, depending on CT is recommended. Early close reduction is recommended. Management of patient with acute spinal cord injury, monitored setting is recommended. So this is actually WFNS Spine Committee's website. So if you just go on that, you've got all these publications, and we have added further couple since then. We have got now primary spinal fracture and metastasis of the spine as well in this. So we have got these recommendations, and they have got all these open access journals, and you can get all the data from here. So there is recommendations on one side, and there's publication on the other as well. So you can look at publication, or you can look at recommendations. So it's very simple and it's easily available in open access. This is that patient. So I just put in traction, reduce that. And all I did was I went anteriorly. I usually use long screws to ensure that I've gone all the way in. And if you see here, this disc was disrupted. and a bit of bone was going in, so clean that up and then put in a plate. And this patient, okay, so depending on what kind of ASIA score is, your outcome is going to be different. So this is the most important slide I say to all my residents. 10 to 15% of individuals with ASIA A will convert to ASIA B to D. Only 3% will regain functional strength. Still, 10 to 15% will convert to B to D. So this is what it's important for us to move forward and push. Half of these patients who have got ASIA will develop ASIA B, they will convert to C and D. So it's important that we push them. And if you look at classified C and D, nearly majority of them will ambulate. In this particular case, so we know that if you've got ASIA A and B, you still do your best, because these are the patients who would benefit most, and the outcome could be different as long as we make sure that so let me not go there first. So the most important thing from learning from this is the care that we give. So MAP should be up, tongs to go in as soon as possible if there's a delay. Otherwise, if you're going to theater directly, that's another way of doing things. But if you do that and post-op, as you said, we usually keep the MAP up for 5 days in those patients who have got injury like this and look at their outcome. This particular patient improved to C and is still in rehab. We look at second patient, a 15-year-old boy, presented with history of dive in the pool, all 4 limb weakness, bilateral shoulder abduction to 3, so ASIA A with no sensation below. And this is the scan. Any takers?
Abby, you want to try?
Yes, sir. This is a sagittal CT scan showing pathology at 3, 4, 5, level of 5, 6. This is kind of like a hyperextension injury.
Okay. So again, if we think about how would we classify, so which classification do you guys use?
Can maybe use the AO classification.
Okay. And what about the basic score? What would be the basic score here? So we talked about that, if it's all the cord is involved with no hemorrhages, then you are down to basic score C. And the other thing which is poor outcome is if the contusion is more than 2 level, then obviously in those patients as well, the outcome is going to be worse. So these are predictors which can tell you beforehand what the outcome could be. But obviously we do everything for every patient. So ATLS protocol MAP, and in this particular case, we went anteriorly, put in a pyramid cage, and the patient improved to C in 6 weeks. So this is what we did. Yes, you're right that probably you should do it from posteriorly. I, in majority of cases, do not go posteriorly unless the whole thing is opened up posteriorly, or if I'm uncomfortable. Rarely, once these patients improve, rarely if I see that the movement is there, then I'd go in and put in posterior screws. And I just want to do the minimum possible, and haven't had any trouble with this kind of approach. But at the same time, some people would just do it routinely front and back, and ideally it should be done that way. Okay, so let's look at another case. Any questions regarding these 2 cases before we move on to this case?
Great cases. Thank you for showing them.
Okay, great. So the last case that I want to show is a 20-year-old presented with neck pain, difficulty walking. He had a ground level fall with progressive worsening for 15 days. He had urinary hesitancy. His power was 4 on the right and left, and lower limbs 3/5, and distal was -4. Reflexes were up. JOA was 12. So what are we thinking? Okay, that's a bit too much. Okay, let's see the scan. Sorry about the poor quality of the scan. This is somebody that I did, I think, a couple of years ago. So when we are near in Pakistan or India, we think
Dr. Sharif,
about.
Dr. Sharif, don't give it away.
Oh, okay. So I
That's
already gave it away.
yeah, you kind of okay. Go ahead.
Come on, let's hear. What do we think it is?
Let's start with Brian, Mr. Carlson, junior medical student.
Okay.
Dr. Carlson's taking a photo for ChatGPT. Can't turn it off. No.
I see some stenosis of the spinal canal at around, it's
So if
hard
you
to
see,
count from the picture, maybe C7, C6.
so what do you think this is? Whoops, that's a bit too much now.
Could be like a disc herniation.
Okay,
The
that's
disc
one.
is intact here.
Disc is
So
intact.
this is the giveaway for this particular issue.
Dr. Sigari, you want to try?
Yes, sure. Could it be, did the patient have trauma?
Very trivial. No trauma, but this
Could
was
it
going on for some time. He has some
could
fever
it
as
be
well.
an infection?
So he has cough
Probably
as well.
TB then.
So okay, so if you see here, this particular disc is involved. The disc above and below is normal, and generally, if the disc is normal, that is bad news. That's what we say. We think about metastasis. If the disc is involved, we say it's good news because if it's TB, it's going to work very well. And you can see all this pus going down all the way. And if you see axials, so you've got all this pus and thick granulation tissue in place of that particular body. And this is his CT showing it's all eaten up from front. And that epidural abscess is causing the neurology. Okay. So he underwent corpectomy, paramesh cage, granulomatous tissue identified with necrotic component involving the C6 body. Corpectomy was done. Pathology showed granulomatous inflammation with necrosis suggestive of TB. So you guys also see TB, but you see obviously in immunocompromised patients. But in here, I see a new case every second day of TB. But majority of them would settle down with medicine. Very rarely do we have to operate. I think 10 years ago, we used to operate everybody, but now we realize we don't. And so majority of the time, we don't have to operate. Oops. So this is what we did. So we decompressed, put a cage and fixed. And this is his new MRI. So it's a year follow-up. And it shows that they do very well. TB spine is a very good disease to have because although you need to take this bitter medicine for 18 months or 13 months, but generally speaking, the outcome is excellent. I have yet to see a patient who has not walked with TB spine afterwards. So this particular patient came to my clinic a few days ago. So I've told him to wear a collar when he's traveling. He lives about 600 miles away. So he's very good. He's back to work. Yep.
You removed the infection from the front, and did you put in a bone graft?
Yes. So I put in a cage,
cage.
titanium cage, and I filled that obviously with bone graft.
Bone graft. Where was the bone graft from? Cadaveric or?
No, not cadaveric. So what we generally do is we have iliac crest, then we take that. If you don't have that, you can take any bone graft. TB does not cause problem. Titanium is not a problem with infections. In fact, with infections, it's good to put in some kind of hardware because what happens if you stop the movement, the pain goes away straight away. So, and there is no evidence that it causes harm or it increases the infection in any way.
That's a great case to show us because here in the US, we don't see much of that at all. So it's great to see that for the residents and everyone.
Okay, so let's see. So these are the cases. Is there any questions that we need to ask before we go on to the next session?
Any questions, team? I have a lot of questions for the next session, but any questions for this session, Dr. Hudson?
I had one question actually for the first case. One thing you hear a lot when it comes to spine trauma and especially these three-column injuries is if a patient comes in Asia A, they're complete, fully complete, that's a case that, can wait till the next day versus if it's an Asia B or an incomplete, you take them the same night. What is your practice or what are your thoughts on that? I know the data is kind of mixed.
So we clearly know that 20% of these guys will improve if we are aggressive with them who have HA. So what if it was me or you, your brother, or a family or something, we'd like it done. So we have changed in our setup. Everything is done in the night. So if somebody comes in the evening, they must be done that evening.
Wow.
Having said that, if there is a for whatever reason, a long case or something, because we have emergency 2 neurosurgery theaters, and if they are stuck for whatever reason, yeah, if it's 2 in the morning, you could wait until early morning that time. So it's just common sense that we do. We want to make sure that the staff is proper and they are fresh and will be able to help. We have all the hardware that we need. We have all the equipment we need. We have monitoring available. So all that has to be there. For whatever reason, sometimes monitoring person cannot come at 2 a.m. for whatever reason. We'd wait till 7 a.m. It's much better doing that instead of taking risk. Yeah. So you're very right. It should be done just like any other case. So now we preach this, that it's important that every case, Asia A, B, C, every case should be taken as individual, and those individuals deserve better. And we can do a better job. And we know that results could be better. They've shown that again and again. So maybe the talk I'm giving tomorrow is really all about this, that there's so much we can do better in spine. For whatever reason, we are a little laid back. We wouldn't do that if our finger was stuck in a door. Obviously, we'd take it out as soon as possible. So it's just the same scenario.
Thank you, Dr. Sharif. We have folks from all over the country, all over the world, so everyone says hello. But one question from Dr. Naban. Hi, sir. My name is Dr. Naban, medical student from University of North Sumatra, Indonesia. My question is, in this case of high cervical spine trauma, how do you balance the urgency of decompression with the risk of intraoperative hemodynamic instability?
Yeah, I totally agree. I think depending on how big the contusion is, obviously you can decide accordingly. And depending on how frail the patient is, if patient is young, then I would tell the family the whole scenario and I would try my best. But, at the same time, we have very good anesthetists and they've been working with us for a long time. So generally, we don't run into trouble. But yes, if we find somebody who's got other fractures, etc., and they're unstable, it's probably best to wait until the stability happens. So there's no point taking a risk. But having said that, you just need to balance it. And that can be balanced with the help of opinion from anesthetists, from the ER guys. And we work together very closely. And that's why I think the results could be reasonable. If it's common sense, actually. So there is no fixed rule. But at the same time, we try our best to do things as soon as possible.
Dr. Perzad from Afghanistan asks, do you start anti-TB medications and for how long do you recommend?
So if we operate and if we take it out and we have curetaged and we have taken all of that granulation tissue out, so it's only for 12 months. If we don't operate on those people, conservative treatment, it goes to 18 months. If in 10% of the cases, TB is resistant in Pakistan, India.
Wow.
So in those cases, obviously, the infectious disease people decide when they will stop and what medicine they'd give. So it's a completely different treatment for them.
Fantastic. Well, let's shift gears. I'll invite our Mayo and outside audience to ask questions about career. Dr. Sharif, tell us a little bit about, because we won't get a chance tomorrow, what is your practice like in Pakistan? What do you think is unique, both good and also challenges that you perceive? Because you're very connected internationally. What has been good about your practice? What are some things that are unique that would maybe surprise us if we went there, both good and maybe challenging on both sides?
Do you want me to show some slides?
Would be great.
How do you want them? Okay.
Yeah.
So one of my resident did a lot of MISR, did a lot of work and made this talk. So let me see. I think this is the one. I think for whatever reason, I can't.
It's the bottom go straight
Okay.
down from there.
Let me close this 1 second. No, this is not it. Okay. Regarding your question, what kind of practice I have, I think it's a completely different practice. Can you hear me?
Yes.
Okay. So what we have is, let me see if why is it not. Okay. So majority of the time, it's completely different practice compared to what we have in Europe or in US. So I end up seeing nearly 100 patients every alternate day. But I have like 14 people helping me, my SRs, spine fellows, residents, interns, and there are other helpers just like you have here. So we have the whole works that we have. Let's see. So this is where we are. This is Karachi. So we have a very interesting geography where India is on one side, Afghanistan is on the other side, Iran is down on this side, and we see China up in the north. So all that area on top is, which is with China, is where all the top mountains in the world are. Let me see. For whatever reason, my computer all of a sudden has gone slow. Now let's see. So this is where I was born. Hyderabad is a small city, 100 miles from Karachi, where my father was a doctor. And this is the university I went to as medical college, which is a huge university. So why medicine? Why neurosurgery? Yes, I was very keen since my father and my elder brother both were doctors. My grandfather was actually in police in India, and he migrated to Pakistan. There was a loss of a close relative in trauma, but there was no neurosurgical service in our city. And at that time, I thought, this is not good, and we should do something for it. And that's what I decided, that I should do something. Having said that, I did electives at Harvard during my third year of med school, and I did electives in cardiac surgery and neurosurgery. This is John Shilitio, who used to be the chief there, and he was the really pioneer of craniosynostosis treatment, and had really, really good time. And I was really attracted to brain intricacy and the complexity of heart. And I thought I could do either one of them. So my elder brother was an orthopedic surgeon in Ireland. And so I just went there, did surgical training, first in Navan, Drogheda, and Dublin, and then got into Irish Neurosurgery Registrar rotation scheme. These are the three people who were my main mentors during my residency. Professor Buckley passed away only this year. Charlie Marks is still intact, doing well. Chris Pigeon is also doing well. These people really took my hand and guided me how I should go about it, really pushed me into doing things that I wanted to do. And I did some workshops during that time, and Professor Bernard Gendra was the pioneer in spine surgery in 80s and 90s. And, I spent some time with him, and really that is the time that I thought that I should be doing spine and not anything else. This is Tony Hockley, and this is Bernard Williams, the syringomyelia gentleman. So they both were in Queen Elizabeth Hospital when I went there. And I spent time in the Birmingham Children's Hospital as well during my neurosurgery rotation. These were the mentors that really pushed me into doing better and good things. So Curtis Dickman and Sontag were the people who really pushed me and guided me when I was doing a fellowship there. Spencer Holland was my mentor in spine in Birmingham. And then I came back to Pakistan. My parents were here and I wanted to do something for them. And so I've been working with the Liaquat Medical College and hospital since 25 years. So I started doing anatomy workshops back in 2000 and followed by instrumentation workshops, followed by endoscopy, image guided. And we introduced all these things into Pakistan where we had no instrumentation when I went back. This is Professor Iftikhar Ali Raja, who was really a mentor for me, and he was always there. He would come and learn how to put the screws, learn about anatomy of spine, etc. He was the honorary president of World Federation of Neurosurgical Societies. Um, this is our hospital, and if you can see, there's a cricket ground there. This is our new building, which has all the specialities. This is all our medical college. And then this part here is all that we have for our university. The area which is here is all residential. And this is the gym, etc., at the back that we have. Back here, the neurosurgery department is located here in these 4 areas. What happened was that I was attending World Spine Egypt in Cairo in 2009, and I ended up meeting these 3 people, one from Wisconsin and 2 from Cleveland. And so Ed Benzel, Doug Orr, and Greg Cross were the one who really said, come over and do something with us. And, so we started collaborating, all of them. So I would do a Karachi spine workshop, and people from all over the world would come and attend and teach and train. And we started doing that, and this is going on since 2009. And we have a lot of fun while we are doing this as well. So this is one of our courses recently, and you can see Graham Fegan there as well, along with Moody and Vlad, enjoying, along with Luis Baba and Barbara in this corner, our dear friend. So all of them having great time. Having said that, I've also been involved with College of Physicians and Surgeons. This is one of our courses in college, followed by the examination that we conduct. This is a trip that I did with about 20 neurosurgeons from all over the world. So you can see Henry Schroeder there, Azam, Amjad, Moody, Francisco, Adrian. So a lot of good guys, and we had it amazing. So we went up to Nanga Parbat base camp, which is there. So this is Nanga Parbat, and we went to this base camp or to this corner. We had amazing time, and we plan to do lots of them again and again. And this is the World Federation company that we have. They have guided us, taken us somewhere, and a lot of good friends and people who have been around and have helped us. I've been involved in Dubai Spine Diploma as well, and so these are some of the things that we do. Working in Africa is really at my heart, and we try to do at least 4 live workshops in Africa every year with the Spine Committee, and have done a lot of work there. And at the same time, then we do various consensus meetings with the spine committee, and we come up with consensus. So these are the consensus articles, again, available open access that we do. And we meet up together and then deliberate and come up with consensus. And we have that twice, and a lot of efforts and work. World Federation, I've been involved since 2011 and have been the co-chair of the spine committee, followed by chair in the last tenure, and I have been the coordinator of the World Federation committees. This was the spine committee that has been helping us and do all this amazing work. This is in the Ivory Coast doing a workshop. At the same time, the Nairobi, Latin America that we did doing workshops, then joint meeting with World Federation and the Congress of Neurosurgical Societies. And then all these publications of different things, as I said, metastasis and primary vertebral tumors were just added in last couple of months. CV junction consensus we did, and we again wrote consensus on that. And these were the CV Junction papers that are open access, available on all the consensus that we did in CV Junction. And it's amazing work that was done, and and I've got amazing people working around us. Recently, we did this virtual Young Neurosurgeons conference, and I'm grateful to Bernard as well, who was part of this and really helped us to move forward. And this is one of the conference during that, where you can see Bernard there as well, helping us. And we had all the moderators for young neurosurgeons, and it's an amazing thing. Now I see so many young people. We have to do the second part of it. Bernard, sorry that I'm going to take away some of your young guys and ask them to help us with the conference next time. So we have some amazing time. We do a lot of the World Federation educational courses, and with that, we've been involved in educating people from outside Pakistan as well. I've been president of Middle Eastern Spine Society as well, and I've been visiting professor to various places in US and Europe. I've been the president of Middle Eastern Spine Society, World Spine, doing various of these works, president of Pakistan Society, and have been the dean of the faculty of neurosurgery. And I've been affiliated with various organizations, and a lot of research work has been involved. I published some papers and obviously wrote some books. And we try to build bridges through medical diplomacy. So a lot of communication and activation and working with people, and obviously working with discipline, humility, and learning, that is important. So this is the most important thing that I tell all my residents. Talent without hard work is a tragedy. So we can't have that. We all have talent. We just need to put in a lot of hard work if you want to get somewhere. So we all need to earn our pride. Qualities of a good neurosurgeon: intellectual honesty, precision, preparation, patience. All this is very important. Empathy for our patients, encourage respect. And we expect that you read constantly. Your curiosity should always be there. Initiate, become responsible, mature as you grow. Ask questions, respect the structure. You have to respect the hierarchy and define your cognitive goals every time. There should be no surprises principle. Know your limits. Communicate positively and confidently. Treat every patient with dignity. Guidance through critical phase, long-term investment in patients, positive professional relationship let you excel. So surgery is service and sacrifice. Set goals. Keep learning. Be teachable. Continue learning. This balance ambition with well-being. Education, yeah, you have to be a part of it. As long as you educate, you'll get there. So if you look at this, the first virtual conference we did ended up having people from all over the world with a lot of happiness and learning that is going on. We wrote all that up as well. There is future is innovation and precision, and everything is changing with AR and robotics. So this all is going to change and move forward very quickly. So we need to be prepared and ready for it. Also, this is an article that I wrote way back in 2020. And then since then, obviously, Elon Musk also took up with our friends in with who are next door neighbors to you, the Barrows, and doing all this, trying to help people to walk again. And we should understand the genome as well. Science is evolving, so we must do that as well. Better is possible. It takes moral clarity. So keep teaching, keep serving. And these are the amazing mountains from Pakistan. So hope to see you there soon. Thank you. Thank you.
That was absolutely phenomenal. Let's take some questions. Thank you for taking us on a tour of your career and your geography and location. Questions from our live audience?
Is it okay if I ask a question, sir?
Of course, please.
Thank you, Dr. Sharif, for the very inspiring talk. I wanted to know more about if you could tell us more about the WFNS and how is it a different conference from other conferences that we have here, the CNS, the AANS, and how we as students and learners could be involved in it. Rather than submitting our abstracts, we submitted a lot of abstracts this year, but on top of that.
Okay, so the World Federation is the most diverse and conference worldwide. And the most you learn from it is you cannot have that anywhere in the world. I've been to many AANS, CNSs, and we do learn loads, but the diversity is completely different. Now, lately, in last few years, both AANS and CNS are also becoming diverse, but only for a session or two. Whereas the World Federation is all about people from all over the world. So what we do is anytime we are making any program, we make sure that people are from every continent, one. Second, we make sure that people are from both LMIC and higher income countries as well. Third, we make sure that, gender bias should not be there. We should include the ladies in every part of our research, our work, our presentations, our discussions, panel discussions. We try to have 25% of the people from LMICs and 25% women, and we suggest that. And then on top of it, once you go to conferences like that, you see what those people are doing amazing work with less opportunities. And you learn so much and you realize, oh, I've been wasting all these years. And when I came back here and I realized there was so much more that could be done that I thought, oh, I don't have this instrument. How can I do that? And here we are and we see, and all this is possible. So I think over time, I've learned that you really don't need to spend a lot of money. Obviously, the companies would like you to spend a lot of money, but you don't need to do that. You need to learn everything about those instruments that we have. You need to have courses, you need a workshop, hands-on, etc. WFNS is amazing from that aspect that there are 20 committees which have people from all over the world. So there are no two people from one country. So there are people from all over the world in every committee, and the chairs are from all over the world as well. And so what happens is that they bring in all this diversity into this conference, and I've realized that I have learned much more with World Federation conferences compared to the conferences that I would arrange in Pakistan Society or AANS or CNS, or even for European Society. European Society has became diverse a couple of years ago, but now I think other organizations are slowly getting there as well. But World Federation is a gem among all the conferences that we see. So once you've submitted your abstract, for people who have problems with affordability, they can write for a scholarship. And if your abstract is accepted, then yes, you would be considered for that. So that would be an extra bonus that you could have.
Thank you, sir.
Felix asks, how do we get involved with the WFNS? Who do we contact?
Okay, so it's very simple. Bernard is your contact, no problem, anytime. So anytime. Probably the best thing would be if you go into the WNS website. There is a link that you can click and write. Or what I could do is on the chat, I can share my email. You can email to me, and I would be very happy to pass your.
Sorry, go ahead.
I would be very happy to pass your concern or whatever you want to do or where you want to get involved. If you want to get involved with moderation, involved with helping out, etc., just write to me and I'd be very happy to help.
I would say that also come to Dubai if you can and submit an abstract. I think the abstract center is still open. So Dr. Dunomi, we need your abstracts for Dubai. It's just early December. I think it'd be great. And again, if you need Dr. Sharif's neuro-ophthalmology speaker in Dubai, you couldn't do better than Dr. Dunomi.
Sounds good.
Some people on this call have submitted abstracts, but I encourage everyone to keep pushing those abstracts in as best you can.
Yeah, I think there are an amazing number of abstracts this time, and we are hoping to have a much bigger, better conference. And on top of it, I think full of, we have made sure that every session has a young neurosurgeon also giving a talk. So we are including that, and people are not repeating their talks again and again.
Dr. Naban asks, they're a medical student and asking about remote mentorship. And that's what this program is about. Circle of Wills is about bringing people together. And from this program, you get ideas, you contact professors, you contact other research students, and there is a way to get involved even remotely these days, and it's not easy, but it can be done. Dr. Hudson has about 6,000 projects on his desk, and he's looking for help. So a lot of the folks on this call, I'm sure, Dr. Sharif, if you have good skill, if you want to work hard and work with integrity, most professors in the world would love to get an extra pair of hands, or even if it's just literature research. And then Dr. Aiden Sirhat asks about places that are resource limited. How can surgeons handle spine problems when you don't have access to instrumentation, let's say?
So I think overall, if you see, you don't need much to start with this in care of spine. The instrumentation, which is expensive, which comes from abroad, is quite expensive in places. So, but in Pakistan, we have a industry which makes soccer balls as well as all these instruments that we have. And they supply really cheap. So every time I go to Africa, I take whole loads of instrumentation from there. So India, Pakistan have got this industry, and so we use that, and it's really, really cheap. And at the same time, medicines, etc., is cheap. Anything else that you use is obviously cheap as well. So from that aspect, you really don't need hi-fi stuff to be doing traumatic spine. You just need to be there and make sure you have ways of keeping somebody's blood pressure up. And that is not a difficult job, actually.
We'll take the last question here. I mean, we may not have gotten to all the questions, but Dr. Ramareddy asks about what your plans are for the future of the Young Neurosurgeons Virtual Conference, and how can we, as medical students, get involved beyond submitting abstracts?
I think surely, if you're good, and first of all, I think when you're getting involved, it's important that you have reasonable English. If you want to become moderator, we'd be happy to have you as moderators, as helpers, and maybe in panel discussions, because what you guys bring is something out of ordinary. Whereas routine neurosurgeons would be thinking about same thing, whereas you would be thinking about something new, something completely different. And so we'd be very happy to have you guys. So you can just write to me, and I'll just forward this to my secretary, who will keep a tag. Yes, we plan to do the second part of Young Neurosurgeons Conference within 6 weeks or so. And for that, because what happened was the pediatrics, neurosurgery and trauma was not included in the last conference. So we will include them, and anatomy. So anatomy is obviously for all of us. And so I'm sure everybody, we would be interested in attending that. And then what we plan to do, have panel discussions of different from different parts of the world for people to discuss how they can help each other. So that would be another way of improving things, and that's what we plan to do in the next conference in about 6 weeks' time.
Thank you, Dr. Sharif. Well, we've come to the end of the hour. I want to thank Dr. Sharif for getting up so early in Pakistan to be with us. Thank you, sir. And I encourage everyone to consider visiting Dr. Sharif and his program, and to get involved with the WFNS. And please invite all your friends to join us along with you for grand rounds tomorrow morning at 7 a.m. Phoenix time. Dr. Sharif, thank you so much. Thank you to our whole audience for joining us.
Thank you very much. It's really my pleasure.
Have a beautiful day. See you soon.
Thank you.
Thank you.